Sir, please start in 3, 2, 1. Please start. So we are live.
Good evening, everyone. I would like to welcome you all for today's webinar on clinical updates in lung, breast, GI, and GU and hematological malignancies. For the welcome and introductory note, I would like to invite Dr. Abhishek Bansal sir, who is consultant medical oncologist, SSB Hospital, Faridabad. For the welcome and introductory note,
Good
the
evening and
stage is
warm.
all yours, sir. Over to you, Abhishek.
Thank
Sir.
you. Thank you to the organizers. So, good evening and warm welcome to all the faculty and attendees which are present here and who have joined here and took their valuable time from their busy schedule. So, as you all know, that oncology is a dynamic field with new researches, trials, and drugs coming up every year, or I can say every 3 monthly. So, we as clinicians sh- should uh, 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 should know the latest what is there in guidelines, and for the benefit of our patient, which is our main objective, we should main focus on the survival and the quality of life, improving the survival and quality of life, and so we should be up to date with the latest knowledge in our daily practice. So, with that short introduction and without wasting much time, I will begin today's day one session of oncology updates. So, over to the organizers, please.
For the next talk, I would like to invite Dr. Sunil Pasrida sir, who is senior consultant oncopathology in Rajiv Gandhi Cancer Institute and Research Center. Over to you, sir.
Yeah, good evening all, and thanks for the kind introduction. So, should I share my slides?
Yes, sir, you can please.
Okay, so my slides are moving.
Yes, sir.
Hang on here. I have to share it again. Just a second.
No issue, sir. No issue.
Just a second. Sorry. It's not moving from my screen. Just a minute.
Sir, you can share me your slides so I can share from my end.
Okay, so I'll be talking about the role of pathologist in the diagnosis and mutation analysis in the non-small cell lung cancer. So my slides are moving right now.
Yes, sir.
Okay, so we know that more than 90% of the lung cancer, they are basically non-small cell lung cancer, and the majority of which are actually they are adenocarcinoma. And the role of pathologist in this current era is not only just to diagnose a lung cancer, but also to find out the predictive biomarkers, to find out the targeted mutation so that the patient can be put on the targeted therapy. And why it is important? Because that was highlighted in the lung cancer mutation consortium when the patient were put on the targeted versus no targeted therapy. So we can see in the graphs. So when the patient were put on the targeted therapy as highlighted in the orange graph, so there was a good prognostic separation of the curves as compared to when the patient was not put on the targeted therapy or when no driver was identified. So the consortium demonstrated that the best outcomes they are seen in the patient with identified drivers who are placed on targeted therapy with a median survival of 3.5 years. So majority of these common and uncommon driver mutations are targetable with an FDA approved agent or something which is on the clinical trials. And in the last 1 decade, we have seen there is an unprecedented evolution of the therapy in the lung cancer. And we have realized that it is not a single disease, but it's a many. And in fact, similar is we found the evolution of the biomarker testing in the lung cancer. And we have found that it's actually a moving target. So till recently, we have broadly classified the testing modalities into the two major groups. One is a minimum necessary, which is the must-do test, that is the EGFR, L-cross, and PDL1. And then other is the recommended like RET, MET, HER2, KRAS, NTRK, and even beyond. So we know that the EGFR, L-cross, the importance was established even a decade before, and we know that they have actually stood the test of time in the last decade. So I will not be talking about these mutations because we are all well versed with these mutations and we are practicing also in our practice for the last 1 decade. So I'll be talking more about the potential application in the uncommon mutation as well, which is beyond the EGFR, ALK, and ROS. So these are the basically emerging biomarkers. So the most important is the exon 20 insertion mutation, and in the category of the EGFR mutations in NSCLC, approximately 10% of the patients they have the EGFR exon 20 insertion mutations, which occur as in-frame insertion in the EGFR kinase domains. The demographics are quite similar to those of the patient with the classical EGFR mutations, like more common in the females, non-smokers, and they had a lower overall survival and progression-free survival than those with the common EGFR mutations like classical, the exon del19 and L858R in exon 21. So these insertion mutations, they are in the exon 20, the C helix or the loop following the C helix, and the majority of which you can see in the figure, they are between the codon 766 to 775. But there is a one peculiar mutation you can see between the codon 763 and 764, which is very much responsive even to the first generation TKIs. Except that all other EGFR insertion variants identified till date, they have found to be resistant to the early generation EGFR TKIs. So this was a large study at the MSKCC, and in which there were approximately 6,290 patients with the NSCLC, and they found 2% of them, they were having a EGFR exon 20 insertion mutation, while 17% had EGFR del19 or 858R. So what they found, the peculiarity was that here you can see that in the graph, in the exon 20 insertion mutations, they have a very low TMB as compared to the del19 858R mutation, or when no exon 20 insertion mutations were identified. And in the graph B, you can see that these subset of the exon 20 insertion mutation patients, they were having a high proportion of PDL1 negative immunoexpression. So these are the graphs in which the dotted line are actually showing the EGFR exon 20 insertion mutation, while the solid line is the NSCLC without any targetable alteration. So we can see that in the graph B, this is the time to discontinuation of the treatment when the patient were put on the chemotherapy, and the time to discontinuation of the treatment was actually prolonged when in the exon 20 insertion mutation subsets. And in the graph C, you can see when the patient they were put on the immune checkpoint inhibitor, the time to discontinuation of the treatment was shorter as compared to the other group. And the graph A, the overall survival was comparatively better as compared to the NSCLC when no targetable alterations were identified. So regarding the testing modalities, the NGS is the recommended method, and the heterogeneity of EGFR exon 20 insertion mutation is actually very high. And the PCR modality has a very poor sensitivity, and it is not at all recommended. The two targeted therapies that has been approved by US FDA, that is the amivantamab and mobocertinib, and they are approved for the locally advanced or metastatic NSCLC harboring the EGFR exon 20 insertion mutation, which has progressed after the prior chemotherapy. But very recently, we have found a very encouraging result in the Papillon trial phase 3 global study, in which the amivantamab, when given along with the chemotherapy in the first line, has shown a very good response. So this was the study design in which in the first line, the amivantamab along with the chemotherapy was given, and we can see from the graph it has shown a very good prognostic separation of the curves as compared to when the chemotherapy alone was given. And also the duration of response was also very much superior when the combination was given in the first line. So besides this exon 20 insertion mutation, there are some other uncommon EGFR mutations in which, like you can see, exon 18 G719X, exon 20 S768I, or exon 21 L861Q. So this was a study that was published in JCO, in which the 37 patients they were enrolled, and they demonstrated a favorable activity of osimertinib with a manageable toxicity used for those which harbor these uncommon mutations. And this has been the largest cohort that has been studied till date in the German National Network Genomic Medicine in Lung Cancer. So this was a multi-center study comprising of 856 patients of NSCLC with this atypical EGFR mutation, including the co-occurring mutations that were reported from 12 centers. And the clinical follow-up data was available in approximately 260 patients. So the response to treatment, they was analyzed into the three major groups. The first group was the uncommon mutations, in which these three mutations, which I just alluded in my previous three slides. So here there was a higher efficacy of the EGFR TKIs as compared to conventional chemotherapy. The other group was the exon 20 insertion mutation. So most of them, they were not EGFR TKI responsive. And the third group was a very rare EGFR mutations, like very rare single point mutation or compound mutations. So the response rate to EGFR TKIs was highly heterogeneous because this was a very rare group. So coming to the next important, that is a MET exon skipping mutation or the amplification. So basically, this leads to the dysregulation of the MET pathway, as you can see in this figure on the left side. So when this exon 14 is skipped and it is not included in the messenger RNA transcript, so that leads to the formation of a very important the protein. This protein Y1003 that is formed is actually a truncated protein. So when this protein is truncated, it cannot bind with the CCLB, and there is no ubiquitination. So that disrupts the ubiquitination proteasome degradation pathway. So there is no degradation, and that leads to the constitutive activation of the signals and tumorigenesis. So what are the characteristics of this MET exon 14 skipping mutation? So they are associated, so they are seen in 3 to 4% of all the metastatic NSCLC, and they can be associated with MET amplifications, the copy number variants. They are commonly seen in females, the elderly, non-smokers, and highly predictive of response to the MET inhibitors. And also the overall survival, you can see that the MET exon 14 skipping mutations, they have a poor prognosis. The MET amplification is also one of the important mechanism for the MET dysregulation, and the MET amplification is regarded as a primary driver gene and also one of the main mechanism of EGFR TKI resistance. And depending upon the assay and the positivity cut point used, the occurrence of the de novo MET amplification is about 1 to 6% in lung cancer, and many studies they have associated MET amplification with the shorter overall survival. So the high amplification is the MET to the SEP7 ratio is more than 5, or MET gene individual copy number more than 10 appears to be the strongest predictor of the true MET-driven tumor, which is seen in approximately 0.4 to 0.5% of the lung adenocarcinoma. And similar to the MET skipping mutation, the MET amplification is also associated with the poor survival as seen in this Kaplan-Meier survival curves. So based on the geometry, these trials, and so capmatinib has been approved by the FDA. So capmatinib shows substantial anti-tumor activity in the patient with advanced NSCLC with the MET exon 14 skipping mutations, particularly in those who have not been previously treated. And also the efficacy in the MET amplified advance was higher in the tumors with a higher gene copy number than as compared to those in which with the lower gene copy number. Another drug which has shown encouraging results in the VISION trial was the tepotinib in the patient with the advanced NSCLC with the confirmed MET exon 14 skipping mutation. The use of tepotinib was associated with a partial response in approximately half of the patient. So the RNA-based NGS is much preferred over the DNA-based NGS, and because the RNA sequencing has the advantage of encompassing all the causal genomic events that actually lead to exon 14 skipping, hence being more sensitive. The RNA sequencing detects the fusion of exon 13 to 15, and in one study, approximately 60% of the RNA positive results, they were found to be false negative in the DNA assays. So this I just show you diagrammatically like how RNA-based NGS is more sensitive and accurate. Like this is the normal messenger RNA, and it has a n number of base pairs. So when exon 14 is skipped, you can see here that the number of base pairs is now will be n minus 140 because 140 base pair is attributed to the exon 14. So coming to the HER2, it is a EGFR. HER2 is an EGFR family receptor tyrosine kinase, and it is seen in 2 to 4% of the NSCLC tumors, commonly in the non-smokers and females. And majority of these mutations, HER2 mutations, they are the in-frame insertion in exon 20, and very few show point mutation in exon 20. They have a worse overall survival than other subtypes in the lung cancer mutation consortium. Again, NGS is the recommended modality. Early phase clinical trials suggest that the patient with the tumor harboring the HER2 mutations who progressed on chemotherapy may respond to trastuzumab-based regimes. And recently, FDA has granted accelerated approval to the FAM trastuzumab deruxtecan for the HER2 mutant NSCLC, and the efficacy for the accelerated approval was based on the Destiny Lung 02 trials, and that was published in the JCO in 2023 September. And they found in this trial that the trastuzumab deruxtecan they demonstrated a clinically meaningful response at both the doses 5.4 or 6.4 milligram per kg. However, the safety profile was acceptable and generally manageable, favoring the dose of 5.4 milligram per kg. Coming to the RET rearrangement, the RET gene encodes a cell surface tyrosine kinase receptor. Their arrangements are seen in approximately 1 to 2% of the lung adenocarcinoma. They are quite often seen in young never light smokers. And testing method, again, it is the NGS which is recommended, and FDA has approved two drugs, selpercatinib and pralsetinib, for the metastatic RET fusion positive NSCLC. And this was the ARROW trial in which the encouraging results were shown for the pralsetinib treatment, which produced robust efficacy and was generally well tolerated in the treatment-naive patient with advanced RET fusion positive NSCLC. And in the patient with the measurable intracranial metastasis, the intracranial response rate was around 70%. Coming to the NTRK1 rearrangement, the NTRK1 gene encodes the tropomyosin-related tyrosine kinase A, and up to 1% of prevalence is seen in the NSCLC. And the two drugs, larotrectinib and entrectinib, are the drugs that has been approved as an oral TRK inhibitor in a tissue-agnostic fashion. Again, the recommended method is NGS, and FISH as a single gene assay, which is not feasible. And there is an immunohistochemistry which we are using in our department for the last 3 years, the clone EPR17341. However, it is required just for the screening. If the I3 is strong positive, one has to confirm with the NGS or FISH, just like we are doing for the ROS1. But again, to highlight the importance that the standalone tests are not cost effective and feasible. Coming to the new regulins, they constitute an integrate family of the structural related cellular growth factors ranging from NRG1 to NRG6. And the fusion involves these are very rare, and they cause the abnormal production of the EGF-like domain of the NRG1 on the cellular membrane that results in the constitutive activation of the various pathway leading to tumorigenesis. The prognosis is not promising. It's a bad prognosis associated with a higher probability of extrathoracic metastasis and a bigger tumor size. The prevailing literature has suggested the poor activity of chemotherapy and immunotherapy in the NRG1 fusion cancer. The two drugs in the trials have shown a beneficial effect for the NRG1 fusion cancer, that is the zenocutuzumab and saribanutumab, and they act by inhibiting the receptor ERB2, ERB3 heterodimerization. The very important is this is the KRAS mutation. So the activating KRAS mutations, which activate a number of downstream signaling pathways, they are observed in approximately 25% of the lung adenocarcinoma. And in the category of KRAS mutations, approximately 50% are G12C, that is the glycine to cysteine mutation. So all in all, we have 13% of all the lung adenocarcinoma that has the KRAS G12C mutations. Sotorasib is a drug which is approved by FDA for this mutation for the locally advanced or metastatic NSCLC who have received at least one prior systemic therapy. Another important drug is the adagrasib that has also been in the trial have shown in the Crystal 1 trial has shown a very good encouraging results, and also the drug has shown a good therapeutic effect on the NSCLC with the intracranial metastasis. Again, the recommended method is the NGS. So optimizing the biomarker identification. So NGS is now much more preferred over the single gene assay because NGS is tissue proficient. 10 nanogram input of DNA and RNA is good enough. It is also resource proficient. One experiment, you have one platform. The variant allele detection cutoff is 5%. Hence, it overcomes the problem of low tumor fraction. It also maximizes the detection of the actionable and also the other driver mutation. And based upon the type of the alteration, like whether it's a tier 1, tier 2, or tier 3, the patient can straight away receive the targeted therapy, or they can be subsequently recruited in the clinical trials. And the bigger strength is that NGS can use plasma even as a sample. However, turnaround time is still a problem. So coming to the actionable mutations that are actually beyond the driver mutations. So actionable targets. So the molecular testing in advanced NSCLC is not only just limited to the search of driver mutations. Much attention has been given to identifying the markers that can actually predict the response to immune checkpoint inhibitors. So as of now, for the immune checkpoint inhibitor, there is no robust biomarker, and these are the various biomarkers at our disposal. We know, and of all these, it is the PDL1 that has been established as a predictive biomarker for immune checkpoint inhibitor in NSCLC. Not a very robust biomarker, but still the best we have. So recently, they have found that when there is a co-mutation of the KRAS and the G12, so when there is a co-mutation of the TP53 and KRAS G12C, so this has shown in various studies that it has a very good response to immunotherapy. And also, this was a important publication in the JTO just 2 years back, in which the authors have found that there is a diminished efficacy of the PDL1 inhibition when there is a concomitant KRAS mutation along with the STK11 or KEAP1 mutation in lung adenocarcinoma. So here is the graph on the left side. You can see that there are two graphs. So the graph A is when there is a concomitant mutation of the KRAS mutation along with the STK11 mutation. You can see the red bar, the response rate is very poor, which was statistically highly significant. Similarly, in the graph C, you can see that when there is a concomitant KRAS mutation along with the KEAP1 mutation, again, the red bar is showing that the response rate was very poor to the immune checkpoint inhibitors. So STK11 and KEAP1 mutations, they confer the worst outcomes to immune checkpoint inhibitors among the patient with KRAS mutation, but not among the KRAS wild-type lung adenocarcinomas. So STK11 and KEAP1 mutation could potentially be the predictor of worse outcome to the both chemotherapy and immunotherapy. This is due to their pleiotropic effects on the cancer cell metabolism and immune system engagement. However, conversely, STK11 mutation does not seem to affect the efficacy of KRAS G12C inhibition in the patient with the KRAS G12C mutated NSCLC who are receiving sotorasib. So to conclude, there is an extensive role of biomarker testing in the metastatic or advanced NSCLC. And there is a potential application in uncommon mutation and emerging biomarkers. The broad molecular testing NGS helps the investigators to identify the additional unrecognized targetable mutations for the development of newly highly specific targeted drugs. And it's incumbent upon pathologists to make the testing reliable by optimizing the pre-analytical, analytical, and post-analytical steps. Thank you so much.
Thank you, Sunil sir. For the next talk, I would like to invite Dr. Pooja Babbar ma'am. Ma'am is Senior Consultant Medical Oncologist, CK Birla Hospital, Gurugram. The next session is sponsored by AstraZeneca. Over to you, ma'am.
Good evening, everyone. Thank you, Dr. Abhishek and AstraZeneca for providing this opportunity. I would be sharing my screen. Are my slides visible and are they moving?
Yes, ma'am. Your slides are visible.
Okay. So, optimizing treatment decision in unresectable stage 3 non-small cell lung cancer, a case study. So, slides are provided by AstraZeneca. So, Mr. X, a 59-year-old gentleman, presented on 17th July 2021 with cough and weight loss for past 3 months. There was no history of any comorbidities, and patient came with this chest X-ray, and we can see the lesion. So on 3rd July 2021 on CT scan, there was a well-defined mass in right upper lobe, as we can also see in this X-ray that there is a mass in the upper lobe, and there were few lymph nodes being paratracheal and hilar region. So probably mediastinal lymph nodes and ipsilateral hilar lymph nodes were involved. On PET-CT scan done on 11th of July, showed posterior segment of upper lobe, a metabolically active enhancing soft tissue mass lesion, and active mediastinal and right hilar lymph nodes. On histopathology, it was moderately differentiated adenocarcinoma lung. MRI brain showed no significant abnormality. So as we know that in stage 2, 1B onwards, mostly for stage 2 and stage 3, we also perform MRI brain in cases of CA lung because of high incidence of brain metastasis, and there were no significant abnormality was detected. So for all the lung cancer cases, we do test molecular testing. So PDL1 testing was 20% and EGFR was negative in all the tumor cells. So now coming to the staging, as we know, the clinically it was CT3 because of the tumor size more than 5 centimeter, and 2 because because of the mediastinal lymph node involvement. So it was stage 3B according to 8th edition, which was active from 2018. So as we can see that stage 3 is a heterogeneous group. It comprises patients from all the subgroups starting from T3, N1, T4, whether it is N0, N1, N2, N3, T4, all the subgroups are included in stage 3. So the profile varies from stage 3A, 3B, and 3C. 3C mostly being T4, T3, T4, N3 disease. So the final diagnosis is right lung, non-small cell lung cancer, stage 3B, adenocarcinoma, EGFR negative and PDL1 positive. So what are the treatment options in stage 3? So as we know that in lung cancer, except the peripheral lesion, which is less than 2 centimeter, which is, T1 with the negative lymph nodes on PET CT scan or CT scan, rest all the staging, we do a comprehensive mediastinal staging. And here, since it is stage 3, the treatment options remain limited. Now, there are 3 types of modalities, either surgery, chemotherapy, radiation therapy, and consolidation therapy after the definitive treatment. But being N2 nodal disease, most likely it is an unresectable disease, and chemotherapy and radiation therapy are the most likely option. So these sequencing could be either concurrent versus sequential or induction or definitive, followed by a consolidation therapy. So in this slide, we can see the outcomes of definitive chemotherapy in unresectable stage 3B. And as we can see, cisplatin etoposide, cisplatin vinblastine, PEM, which we give in non-squamous stage 3A and B, and paclicarbo. So the most common regimens. So the most common regimen which we use for a squamous is cis-etopo or paclicarbo, and for non-squamous we use cis-PEM. And the concurrent radiation doses vary from 60 to 66 gray. So the maximum survival which we achieve with these concurrent regimens are close to 2 years, with a progression-free survival ranging maximum up to 11 to 12 months. So this is the maximum we have achieved in stage 3 unresectable cases. And as we know, as your stage progresses, starting from stage 1B, there are 25% chances of disease recurrence or, untowards event like death. As we progress to stage 2, these untowards event increases to 30 to 50%, being 75% in stage 3. So maximum 5-year survival is ranging between 15 to 25%. And as compared to sequential, concurrent chemoradiation increases your 5-year survival rate more than sequential by approximately 4 to 5% over 5 years. And coming to the locoregional relapses, concurrent chemoradiation also reduces the risk of locoregional relapse, as we can see, as compared to the sequential therapy. So the plan was made, patient was started on chemoradiation, started on 29th of July 2021. EBRT, we give 60 gray in 30 fractions, followed by weekly chemotherapy, pacli plus carbo, 4 cycles, which was the last day was 10th of September. So post CTRT, these are the follow-up scan, and we can see the disease has regressed, and we can see some post-RT changes. consolidation therapy has actually not shown any benefit in stage 3. So as we know, the PFS benefit which we get is close to 9 to 11 months. And the OS benefit which we get in unresectable stage 3 is maximum up to 2 years. So a lot of strategies were being established so as to increase the benefit in terms of outcome like OS and PFS in stage 3. So one strategy being the consolidation therapy, and it has been seen that by consolidating by 2 to 3 cycles of chemotherapy post completion of definitive CTRT has actually not resulted in improved PFS or OS benefit. And so all are the negative trials with no benefit. So improving outcomes in unresectable. So one strategy is giving concurrent chemoradiation. As we have seen that as compared to sequential chemoradiation, there is 4 to 5% benefit in concurrent strategy. And to improve the prognosis further, certain more strategies were included, like including the induction chemotherapy. Induction chemotherapy is usually given in those patients of stage 3 where your radiation portal is too big, and doing upfront radiation would cause more of radiation pneumonitis. So in order to reduce the bulk of disease so that the disease can be covered in a single radiation portal without causing unnecessary toxicity, this being one of the strategy. But again, induction chemo has also not shown benefit in terms of OS or PFS. Second strategy is increasing radiation dose by adding certain boost, which has also not shown much improvement in outcomes. And consolidation chemotherapy, as we have seen in the previous slide, has not shown any benefit. So now the next strategy was immunotherapy, which has been recognized as a safe and effective option as an adjunct to concurrent chemoradiation. So Pacific trial is a phase 3 randomized, double-blind, placebo-controlled, multi-center international study. So the profile of the patients which were included in this trial were the patient who had a dismal outcome, in particular stage 3 unresectable non-small cell lung cancer, who have not progressed following definitive at least minimum 2 and more than 2 cycles of platinum-based chemoradiation, 18 years of more, or a good performance status 0 to 1, expected life expectancy of at least 3 months and more, and archived tissues were collected to do the PD-L1 testing baseline. And then these patients were randomized within 1 to 42 days. So maximum 6 weeks post chemoradiation, they were randomized to durvalumab in 2:1 fashion. Durvalumab versus placebo. And the stratification was by age, sex, and smoking history. Primary co-endpoint was PFS and OS, and key secondary points were overall response rate, duration of response, and safety profile. Now, coming to the baseline character, it was a well-balanced study. If we see in both the arms, the median age was 64, the sex distribution was okay, and most importantly, 25 to 30% of the patient were Asian, 50% of the patient had stage 3A, and the rest being 3B and others. Good performance status was there in majority of the patient. EGFR mutation was positive in only 6%. So it actually did not include EGFR mutation positive patient. As we know, in a driver mutation dependent lung cancer, the outcomes with immunotherapy is dismal. So this is the updated 5-year overall survival. And as we can see, there is a very good separation of the curve starting from the beginning till the end. And that separation is being maintained even after 5 years, with median overall survival in durvalumab arm being 47 months versus 29 months in placebo. So close to 1.5 years of improvement in OS by giving durvalumab. So 43% OS at 5 years. And regarding 5-year progression-free survival, it is 17 months in durvalumab and 5 months in placebo. And as we can see, it is 33% of the patient were progression-free at the end of 5 years compared to 19%. So there is also a real world data, which is an observational real world outcomes with durvalumab after chemoradiation in patients with unresectable stage 3. Even a Pacific R trial has been done so as to document the real world scenario in an observational study regarding the patients who were post CTRT and on durvalumab maintenance. As we know, Flatiron is a medical record database, a very big US database electronic, and it's a retrospective observational cohort study, and 332 patients who received durvalumab were analyzed, and 50% of the patient actually started durvalumab, within those suggested period of 42 days, and 40% received, for more than 1 year with a good follow-up of 1.5 years. And regarding the endpoints, the primary endpoint evaluating real-world effectiveness, including time to first subsequent therapy. So durvalumab also prolongs time from durvalumab initiation until the start of first subsequent anti-cancer therapy. It also delays the development of, development of metastasis. Either it is, in, either it is extra, either it is inside the lung or outside the lung. There was benefit in distant metastasis as well as the locoregional metastasis with the initiation of durvalumab. And as we can see that, the time to first subsequent therapy was also prolonged. And also the real world progression-free survival, as you can see, it is close to the trial data, which is 18 months, and OS was also not reached since it was a follow-up of 1.5 years. So this data also aligned with the landmark trial, and this shows that durvalumab after chemoradiation is effective and well tolerated in patients with unresectable stage 3 non-small cell lung cancer. Same a Pacific R trial was there, which was again an observational study. And it has shown that, the patient who started on durvalumab within 14 days of completion of radiation had an improved efficacy outcome as compared to the one who started treatment more than 14 days from completion of radiation. Though pneumonitis was one of the most common adverse event, and they were more common in first 3 months, which was, mostly 10%, which led to maximum treatment discontinuation, like more than half. So now coming back to the case, the patient was started on durvalumab on 30th of September. As we have seen, it is 20 days post chemoradiation. So 3 cycles were completed on 3rd November 2021, and a follow-up PET CT scan was done on 11th November 2021, and we can actually see a good response. Again, since there was a good response, so the patient was continued to receive the therapy. And this is the chest X-ray. As we have seen initially, there was an opacity in the upper lobe, which is not visible now. And these are the follow-up scan till Feb 2022, showing a good response was continued. So patient totally received 15 cycle and then presented with complaint of chest pain. On 1st of June 2022, a scan was done and we can see some lesion. So patient is likely to progress, and what is the next line of therapy? Since patient has been exposed to immunotherapy, so the next line of therapy would most likely be a chemotherapy. So what is the pattern of disease progression? That is the first progression by location. So in the Pacific trial, it has shown that even subsequent rates of first progression was also reduced in durvalumab arm compared to placebo, which was 45% compared to 65% in placebo. Intrathoracic progression was the most common in durvalumab arm. So as you can see, this is the durvalumab arm, and the RACES progression was 45% compared to 64% in placebo arm. The maximum benefit we could see in intrathoracic, which was 36% progression versus 48% in placebo, and extrathoracic being 6% versus 13%. And the pattern of disease progression time to intrathoracic progression only or death. So as we can see, even that time was prolonged. The time to intrathoracic progression was prolonged by 2 years as compared to placebo, which was 9 months. So first subsequent therapy after discontinuation of durvalumab, as we can see that 40% of the patient, who were on durvalumab arm received a subsequent therapy versus 54% in placebo arm. And subsequent therapies were the most common first subsequent anti-cancer therapy in both the arms, as we can see, because already the patient has been exposed to immuno. The subsequent immuno in this arm was 4% versus 13% in placebo. Coming to the safety parameters, as we can see, the most common, safety parameter which was of concern was any grade pneumonitis, which was 33%, so which was 10% more in durvalumab arm. It was 34% in durva versus 24 months in placebo. So any grade pneumonitis was 10% more in durvalumab arm. And as we know, majorities are grade 1 and grade 2, and very less are grade 3 and grade 4. And as we know, in grade 1 and grade 2, we just have to halt durvalumab, give a break till those sign and symptoms resolve. Whereas we have to start with low dose steroids in earlier grades, and with grade 3, grade 4, we have to stop the therapy, start high dose steroids, wait till the radiological signs of radiation induced pneumonitis stop. So this we know how to manage. So the key takeaways are MDT approach actually gives the best outcome in stage 3. Concurrent chemoradiation gives better outcome than radiation alone or chemo alone or sequential regimen. And it has shown benefit of up to 4.5 to 5% in 5-year in terms of OS. Consolidation chemotherapy has not shown any improved outcome. The only strategy which has shown to improve the outcome, especially in unresectable stage 3, N2, N3, is immunotherapy, and which has shown benefit in terms of 5-year OS, which we have seen up to 1.5 year more, close to 45 months, and PFS benefit close to 17 months. Durvalumab should be considered as a treatment option in unresectable stage 3, specifically the patient who has not progressed on chemoradiation, patient who had a good performance status, patient who does not have radiation pneumonitis, higher grades. It improves outcomes in all the subgroup, irrespective of PDL1 or EGFR status. Though EGFR was very less, it was less than 6%. And regarding PDL1 status, the subgroup was divided into TC less than and more than 25%, and it has shown benefit in both the groups. And the OS benefit was actually not seen in a PDL1 less than 1%, but that was a post hoc group, and it was not meant to show benefit. It was not pre-specified to show benefit in this particular subgroup. That is a subgroup which has TC less than 1%. Durvalumab is the new standard of care in stage 3 unresectable non-small cell lung cancer post CPRT. And thank you all. Thank you for providing this opportunity.
Thank you, ma'am. Such a nice talk, ma'am. Any questions is there? Thank you, Pooja, ma'am. For the next talk, I would like to invite Dr. Abhishek Bansal, sir. The session is sponsored by J&J. Sir is consultant medical oncologist, SSB Hospital, Faridabad. Over to you. Hello. Over to you, sir.
Yeah, hello. Will you do the slides for me? Hello.
Sir, you haven't shared your slides, no?
Acha. Just let me share my screen then. Is it visible?
Yes, sir.
Hello. Oh. So good evening to all present here. So today I'm going to speak on the topic hidden EGFR threats, the role of amivantamab. So lung cancer remains one of the deadliest and most common cancers, and you can see the incidence among the incidence is also quite high in the percentage of all cases, 12.2%, and the percentage of all cancer-related death is the most common, uh, causing the mortality. So, as you all know, most lung cancers are diagnosed after metastasis and have poor prognosis. So, localized and regional are reasonably low, like 19 and 22%, and mostly are diagnosed in the distant subgroup, which are around 55%. And the relative 5-year relative survival rate for distant late stage lung cancer is only 7%. So, coming to the driver mutations which initiate and maintain the cancerous state of cells, this was, I think, initially discussed by Sunil sir in the previous slideshow. So, this is all the driver mutation which are driving force behind the tumor growth, so which we can target and have an actionable mutation. So, coming to the EGFR signaling mutational pathway, this EGFR signaling coordinates with other signaling pathway to generate a robust and coherent biological outcome to maintain cell growth, survival, and migration. And if there is any mutation, that this leads to cancer by sustained cell growth and promoting metastasis, preventing apoptosis, and reprogramming metabolic networks. This homeostasis is disturbed. So coming to the EGFR mutations, as already discussed earlier in the earlier lecture by Sunil sir, that EGFR mutations are amounted to around 28% in the metastatic non-small cell lung cancer, and other being KRAS and other mutations like other common mutations like ALK and ROS being the other common, and uncommon being which was discussed are MET, RET, and can say HER2, HER2. So, so coming to the further percentage in the EGFR mutations, the EGFR exon 20 mutations are the third most prevalent after the exon 21, followed by exon 19, the third is exon 20 insertion. So coming to this various exon 20 insertion, you can see. So these mutations occur within the tyrosine kinase domain, and you can see the in-frame insertions in exon 20 of the EGFR gene were among the first EGFR mutations to be identified as oncogenic drivers in NSCLC and account for up to 12% of EGFR mutated NSCLC. This is the exon 20 insertion mutational biology, and you can see that exon 20 insertions are either in-frame insertion or duplications. Most insertions comprise 3 to 21 nucleotide base pairs, and the location of these insertions can influence drug and ATP binding kinetics. And most insertions occur between amino acid 761 to 775 and can be divided according to the protein structure they form. So, unlike mutations in exon 19 and 21, 20 mutations are typically resistant to the standard TKI, in which A763, Y764 is an exception, and exon 21 and 19 cause confirmation changes that cause confirmed sensitivity to EGFR TKI. But exon 20 insertion mutation cause conformational changes that reduce TKI binding. Insertions after site 764 may form a wedge at the end of clinical lesion that it looks like an active stage. Low response rates have been observed with the exon 20 insertions, as discussed earlier also. So these are unique and distinct from the common EGFR mutations. The standard EGFR exon 19 deletion, you can see this is less affinity for ATP and higher affinity for TKI. and sensitive to TKI with wide therapeutic window. But the exon 20 insertion, these are statistically hindered drug binding pockets, similar affinity for ATP and most TKI to wild type EGFR. This are resistant to most TKI with loss of therapeutic window. So the prevalence of the exon 20 insertion mutation, you can see in the USA it's 5 to 20, it comprises of the 5 to 12%, in the Europe 4 to 12%, Asia Pacific 1 to 5%, and so coming to the limited treatment options, the platinum-based therapies are the most common first-line treatment for patients with EGFR exon 20 insertions, and you can see the PFS is around 6.6 months and 17.4 months is the OS, median OS, in which platinum-based therapy are combined with the immunotherapy agents. And still the responses are not much good, and there is no standard of care for the second line treatment. If the disease has progressed after this first combination of chemotherapy and immunotherapy, we can use either chemotherapy if not used earlier, or second line chemotherapy, or immunotherapy if not used earlier. And you can see there is limited efficacy, and the PFS is also quite low. So, platinum-based chemotherapy is recommended for first-line treatment of EGFR exon 20 insertion mutation, and median PFS is 5 to 7 months with first-line chemotherapy. But in a real-world analysis, the median OS was higher in EGFR exon 20 insertion mutation treated with platinum-based chemotherapy compared to patients treated with an EGFR TKI or an immunotherapy monotherapy, as they are resistant to the standard EGFR TKI. So the median PFS was 5 to 7 months in EGFR exon 20 insertion in treated with chemotherapy compared with the other treatment patterns, agents of like TKI or immunotherapy. So you can see that the median PFS in the sensitizing mutations is quite high versus the exon 20 insertion mutations, in which it is quite low. And response rates with TKI for exon 20 insertion mutations is 0 to 9% only. And they respond poorly to first line TKI indicated for common EGFR mutations. The NCCN guidelines do not recommend TKIs indicated for EGFR mutation as a treatment for exon 20 insertion mutation. For most patients with exon 20 insertion mutation, first-line therapy, as discussed, is like platinum-based chemotherapy only or along with combination of IO. And targeted treatment options are recommended as a subsequent therapeutic option for patients who have progressed on or after initial systemic therapy. And EGFR TKI indicated for common EGFR are not recommended in first line or subsequent line. The patients with EGFR exon 20 insertions have a poor prognosis than those with the common EGFR mutations. And understand the unmet needs, the real-world study was conducted in 2014 patients with EGFR non-small cell lung cancer, and EGFR 20 insertions were the third most frequent as discussed, and they are insensitive to the TKIs, and though no targeted therapy has been approved till now, and prognostic value of exon 20 is poor as compared to the standard EGFR mutations, and the predictive value is also there in which they respond poorly to the TKI. So the key eligibility criteria in which this was the Flatiron database in which these three mutations were there, the standard EGFR and the uncommon exon 20. And treatment was initiated in 90 days of advanced diagnosis and predictive value of any TKI treatment. And you can see that the overall survival is quite less of the EGFR exon 20 insertions compared with the standard EGFR, and the p-value is also significant. Patient with exon 20 had a poor prognosis and 70% increase risk of death. Medium OS was 16.2 months only compared with the 25.5 months in the common mutations. And real world progression free survival is also quite less, and the graphs have separated. The standard ones are still doing good, and the exon 20 have fallen quite low. And you can see that the median OS is only 2.9 months versus the 10.5 months. And this further supports that they had a poor prognosis and increased risk of progression or death with the standard TKIs. So 5-year survival rate for patients with the common exon 20 insertions, standard EGFR mutations is quite high compared with only 8% in the 5-year survival rate of the exon 20 insertion. The molecular testing, as discussed earlier, that has become a critical diagnostic workup for the targeted therapies. So molecular tumor specimen should be tested for specific EGFR mutations, including exon 20 insertions. And BRAF, ALK, and ROS should be tested as routine. And other potential which were discussed, which are the uncommon, are the PDL, KRAS, RAT, anti-ARC, and MET exon 14. So coming to this molecular testing, you can see this is the treatment and the molecular testing, in which we can do standard testing on the solid tissue or do a liquid biopsy and start our treatment according to the targetable mutation. So coming to the selection for targeted therapy, if it is mutation positive, then we treat with targeted therapy, because benefits to diagnostic testing is increased likelihood of response to the targeted therapy and cost saving. So as discussed that PCR is less sensitive than the NGS for detecting the EGFR mutation, and specifically I think for exon 20. So analysis, you can see the advantage and disadvantage that it analyzes on this particular gene variants at specific location, can only detect predetermined target sequences, effective for low target numbers, cheaper and short turnaround time, but detect broad panel. The NGS can detect broad panel of mutations and can detect all variants without prior sequence knowledge, and preferable for many targets, and but it is costlier and it has a long turnaround time. So PCR based test only detect a limited number of EGFR exon 20 insertion mutations, which we discussed earlier by Dr. Sunil sir. That only PCR pickup rate is only 5% as compared to the NGS, which is more than 70%. So we should all go for NGS based testing for the EGFR exon 20 insertion. So they are unable to, the commercial PCR are unable to identify 50% of the EGFR exon 20 insertion mutations. Coming to the guidelines, for the biomarker testing, the NCCN guidelines advise broader molecular profiling and diagnosis of advanced or metastatic cancer with the goal of identifying rare driving mutations. Broad molecular profiling is a key component of the improvement of care for patients with NSCLC. It is recommended that at a time when feasible, testing should be performed via broad panel-based approach, most typically by NGS. And Indian consensus should be tested, and reflex molecular testing can be performed using NGS. And the ISCLC or AMP guidelines recommend genetic sequencing over the single test to identify other treatment options beyond the EGFR, ALK, and ROS. NGS enables the survival of the mutational testing, EGFR, ALK, ROS, as well as other tests. So incorporating plasma NGS testing increases the detection of X-level mutation and improves treatment delivery. So detection of X-level mutation increased from 20 to 35% when plasma testing was added to the tissue testing. So in a nearly a third of patients, mutations were detected only via plasma-based testing. So the NCCN guidelines recommend plasma based testing or the liquid biopsy for patients with metastatic non-small under circumstances, like if the patient is medically unfit for the invasive tissue procedure sampling, or if the initial diagnostic setting, if following pathological confirmation of LSCMC diagnosis, there is insufficient material for molecular analysis, if feasibility of timely tissue testing phase is uncertain, and concurrent DNA testing may aid in biomarker evaluation for treatment selection. So coming to the exon 20 insertions Indian scenario, the reported prevalence of exon 20 insertion mutation is in the range of 1 to 8%. So as you can see, in the various studies, the insertions and the average comes in the range of 1 to 8%. So two retrospective studies reported the efficacy of currently available treatment regimens in patients with exon 20 mutations. That patients with exon 20 had a median PFS of 6 months and a median AFS of 3.8 months. And PFS with TKI was only 1.9 months, and dismal OS. The prognosis of patient with exon 20 insertion mutation remains poor. So coming now to the role of amivantamab, and this is a fully human EGFR MET bispecific antibody, and it binds to the extracellular domain of the EGFR and also the MET, and by targeting active and resistant EGFR mutations and MET mutation and amplification, amivantamab addresses two major mechanisms of resistance to the standard of care. Amivantamab has been addressed for the treatment of patients with locally advanced or metastatic non-small cell lung cancer with activating epidermal growth factor receptor mutations, exon 20 insertion mutation whose disease has progressed on or after platinum-based therapy. So you can see how the amivantamab binds to the exon 20 insertion and targets the so amivantamab has three demonstrated mechanism of action: immune cell directed activity, receptor degradation, and inhibition of ligand binding. So this leads to the cell death and also the receptor degradation. Also lead to the cell death of the tumor cell, and the inhibition of ligand binding also inhibits the tumor cells. So the immune cell directed activity, first mechanism of action, you can see the how these stimulate the natural killer cells and cause the perforin enzymes and to target the cancer cells, and this causes the NK cell killer cell mediated lysis of the tumor tissue. So coming to the next mechanism, EGFR and MET receptor degradation. Amivantamab binds triggers EGFR and MET receptor degradation by the tumor cell. This leads to receptor inactivation. So inhibition of ligand binding also. Amivantamab binds to the extracellular domains of EGFR and MET. This inhibits ligand binding and downstream signaling from both receptors, causing the cell lysis of the tumor cell. So coming to the dosing of amivantamab is administered intravenously once weekly for 4 weeks, then every 2 weekly thereafter. And due to infusion-related reactions, frequency at first dose, infusion via peripheral vein at week 1 to week 2 should be considered, should be given through a peripheral vein to minimize drug exposure in case of an infusion-related reaction. An infusion via central line may be administered for subsequent weeks, and first dose should be diluted as close to administration as possible to allow for maximum flexibility of an infusion-related reactions. So you can coming to the dose of amivantamab in less than 80 kg, it's 1050 mg. Greater than 80 kg, it's 1400 mg. And the one vial of amivantamab is 350 mg and 7 ml. So 3 vials is used in less than 80 kg and 4 vials in more than 80 kg. So you can see the first dosing. You can first we do a week 1 dosing of a split dose infusion in which 350 mg is given on the day 1, and initial infusion rate will be 50 ml per hour, then the subsequent infusion rate is 75 ml per hour, then the day 2 is remaining 700 mg, which is given along with the standard infusion rate as on the day 1. Then the week 2, if there is no reaction, then we can give the full dose of the 1050 mg at the rate of 85 ml per hour. Then the subsequent weeks, we can increase the rate further at the rate of 125 ml per hour. This is coming to the 1050 mg dosing. And the 1400 mg dosing is also similar, in which we give the initial dose of 350 mg on the day 1, then followed by the subsequent remaining dose of 1050 mg dose. Then the week 2, we slightly increase the rate. So coming to the Chrysalis study, the Chrysalis study is a phase 1 study of amivantamab in this patient with EGFR mutated non-small cell lung cancer. Objectives for the part 1 establish this drug, also the safety and efficacy. So basically, the eligibility criteria was metastatic unresectable non-small cell lung cancer, which who had failed the standard of care of therapy, and advanced non-small cell lung cancer metastatic, and there was activating resistant EGFR mutations or MET mutation or application which was present, and the dose of amivantamab was given in a increasing dose escalation pattern of 140, 350, 700, 1050, and you can see that the infusion was like the, as I told discussed earlier, the cycle 1, and then the weekly cycles of day 1, day 8, day 15, day 22, and from cycle 2 onwards we give the 2 weekly regimen. So patients were given the dose of less than 80 and the greater than 80 as discussed, and all patients in part 2 had a baseline MRI. Subsequent screening was decided by the investigators. So basically there were 2 arms in which one was dose escalation of till 1750 and one was the dose till 1050 and 1400 mg. And basically in the cohort D, the EGFR exon 20 insertions was seen, and cohort A was EGFR dependence resistant, cohort B was EGFR independent, cohort C was post EGFR TKI, and E was amivantamab plus lazertinib combination. Cohort M, MET1 was MET application, MET2. So coming to the cohort D study design, the patient with EGFR mutated advanced NSCLC who had the exon 20 insertion mutation and who had progressed on prior platinum-based therapy. And key objective were
Abhishek sir, sorry to interrupt. Kindly conclude your talk.
so coming to the summary of Chrysalis study, amivantamab had a tolerable safety profile consistent with EGFR and MET infusion, and a robust efficacy with an overall response rate of 40%. And it's the first bispecific antibody to demonstrate clinical meaningful activity in patients with EGFR exon 20 insertion non-small cell lung cancer. And it could target other EGFR and MET-driven tumors as monotherapy or combination with chemotherapy. So, most commonly used real-world treatment for post-platinum EGFR exon 20 insertion included. Thank you.
Thank you, Abhishek sir. Such a nice talk. Technical team, kindly stop the recording for the next 2 sessions. Sorry for the inconvenience. The recording will be stopped for the next 2 sessions.
Yes, sir.
Okay. For the next session, I would like to invite Dr. Okay. For the next session, the session is sponsored by Pfizer, and the speaker will be none other than Dr. Sunil Kumar Gupta. Sir is Director and HOD Hematology Oncology, Venkateshwar Cancer Institute, Delhi. Over to you, sir.
Thank you, Dr. Abhishek. At the outset, really thank the sponsor of the scientific program. So, very good evening, friends, ladies and gentlemen. At the outset, I really thank the sponsor of the scientific program, the Pfizer, who has given this opportunity, organizer, Dr. Abhishek. My talk is basically focused to the time to raise the bar for ALK positive non-small cell lung cancer, and you will surprise that 5% patients of non-small cell lung cancer, especially adenocarcinoma, are positive for ALK. And clinically, if you see, there are 4 variants reported by the recent advances that ALK is having a 4 variant. I would like to discuss this time to raise the bar for ALK positive within 25 minutes for your consideration. So this is the disclaimer of the slides, because this slide desk is provided by the Pfizer, so there is no change. I would like to discuss the lorlatinib in detail and just see ALK inhibitor development means the journey of ALK inhibitors. In 2007, with discovery of EMLA4 ALK translocation. This means ecoderm microtubules associated protein like 4 ALK is seen in 5% of lung cancer patients, and you will surprise 5 years later we have a first generation ALK positive inhibitors known as a crizotinib. And in 2015 we developed the second generation ALK inhibitors like ceritinib, alketinib, and brigatinib, and up to 2017 and 18 we have these 3. And second generation ALK inhibitors, alketinib, ceritinib, approved for first line treatment. In 2019 we talked about a third generation TKI, lorlatinib, and in 2001 again US FDA approved lorlatinib as a first line treatment for clinical practice. I would like to highlight one thing. The first generation crizotinib ALK inhibitor, I have first patient who is published in South Journal, where I have mentioned about the patient, those who treated with me in 2014. So unmet need in ALK positive lung cancer, why there is so? Just see, generally young patient, median age 51, routinely non-smoker or a light smoker, and out of that 20 to 40% patients in due course of a time develop the brain mets. And there is a disadvantage of second generation TKI, and in due course of a time we reported that ALK resistance mutations are seen with the second generation TKI, and even the CNS penetration is inadequate of second generation TKI ALK positive patients. So durable control of brain mets in patients with brain mets and preventing brain mets in those without them at the point of diagnosis is remaining unmet treatment need, and that's why we developed the third generation TKI. There is a need for additional ALK TKI that prevent the emergence of resistance for second generation TKI subclone in untreated patients. So once we are deciding about any TKI in ALK positive patient, we always see which one is better and why we are selecting 4 patients. We always see the overall efficacy, overall survival. What is the second line treatment available after that? CNS activity means penetration of this drug in the brain, response rate as per the phase 3 randomized landmark study, and progression-free survival. So I am just discussing the landmark study known as a crown trial for lorlatinib. So just see the schema of this trial. Stage 3B and stage 4 patient, ALK positive, no prior systemic treatment for metastatic disease, PS0 to 2, asymptomatic treated or untreated CNS mets were permitted, and more than one extracranial measurable target lesion as per the REACH criteria 111 with no prior radiation, and randomized into equal 1:1 ratio lorlatinib 100 milligram as compared to crizotinib 250 milligram BD. The important thing was presence of brain mets, yes or no, and ethnicity Asian versus non-Asian. The primary endpoint was progression-free survival by the blind independent central review. Secondary endpoint was progression-free survival by investigator. Overall response rate by blind independent central review. The important thing I want to convey you, the intracranial overall response rate, even the intracranial duration of response rate, and intracranial time to progression was one of the important points of this trial. Overall survival, safety, and quality of life is always important once we are discussing about any drug in clinical practice. So this landmark study clearly shows that progression-free survival is much, much better. You can see crizotinib versus lorlatinib. The classical graph is separated like anything. Even intent to treatment population at 36 months, the graph is again widened, 18.9 versus 63.5. You can see the hazard ratio is very important. Lorlatinib is having hazard ratio of, comparing with the crizotinib, 0.28. And if you see again hazard ratio in 10 to treatment patient is 0.27. So progression-free survival, patient with or without brain mets. You can see those patients on a baseline brain mets. Despite of that, crizotinib is inferior as compared to lorlatinib by the graph clearly show a widened picture. Even those patients, those who are having a without brain mets, the lorlatinib is showing a response which is much, much higher as compared to crizotinib. And the hazard ratio is again 0.21 and brain mets, and without brain mets 0.29. And just see the response rate 7.2 with crizotinib in brain mets and not reachable with the lorlatinib arm. Even in without brain mets, this is 11 months as compared to not reachable with the lorlatinib arm. So now you just see there is a 3 trials: ground trial, L trial for first line, and LX trial as a blind independent central review assess the progression-free survival. I just want to highlight that once we are comparing lorlatinib versus brigatinib versus elcatinib as a hazard ratio trial, you can see hazard ratio is almost double with the LX trial, means elcatinib is showing a 0.50 hazard ratio as compared to the crown trial for lorlatinib, which is showing 0.27, and even the brigatinib is showing 0.48. So hazard ratio clearly shows that this is almost double with the LX trial, elcatinib 0.43, 0.47 as compared to investigator assisted crown trial 0.21 and 0.28. So progression-free survival, if you see 3 year, the 64 with the lorlatinib, elcatinib showing 46.4 and brigatinib 43. I mean, they clearly shows that there is an advantage of third generation lorlatinib as compared to second generation elcatinib and brigatinib. So time to intracranial progression and intent to treatment population, just see the graph clearly shows a widened thing. Even in a crizotinib arm, 37.7 as compared to 92.3 with the lorlatinib. Time to intracranial progression was significantly longer with lorlatinib than that with the crizotinib. So lorlatinib is having a hazard ratio of 0.08, and this is very, very significant as compared to crizotinib, 16.6 months, lorlatinib not reachable till date. So independent blind central review assessed intracranial time to progression in patient with baseline brain mets. Just see, again, the curve is widened. Crizotinib is touching the foot, and there is a 73% patient, even in a prolonged duration, lorlatinib shows a response rate. And just see median progression-free survival not reached with the lorlatinib arm with brain mets as compared to crizotinib 7.3, and hazard ratio is 0.10. So central CNS efficacy of first line lorlatinib crown update, you can see there are 2 things. There is a waterfall chart which clearly showing a intracranial response in patient with baseline measurable brain mets on first line lorlatinib. And you can see the important thing. The patient, those who are having a baseline brain mets, the complete response rate is seen in the tune of 72%, while the LX trial shows 38% response rate. And if you see the patient, those who are having no brain mets, complete response rate is 59%, and LX is showing a 45%. And the intracranial objective response rate, again, you can see 65% versus LX 59%. So intracranial time to progression in patient without baseline brain mets, you can see the graph is again widened, and up to 99% in cases of loratinib arm as compared to 50% with the crizotinib arm. Just see the hazard ratio is 0.02, and out of 112 patients, only one patient developed the brain mets during the course of treatment during the trials. So in summary of efficacy, I can say hazard ratio is very, very important. And if you compare with the alcatinib, this is almost double. You can see progression-free survival in patient with brain mets, hazard ratio is 0.21, and you can compare with the alcatinib, ALEX trial, hazard ratio is 0.4, almost double. Those patients, those who are without brain mets, the hazard ratio is 0.29 as compared to hazard ratio of 0.51. So updated analysis of Crown trial, basically September 2020 to 2021, they mention about the variants, and the important thing which I want to convey you that there is a variant 1, 2 and 3. 1 and 3 are commonly seen. Variant 2 is rarely seen or in less number, but the response rate is different in all the variants. Variant 1 is having a good response rate, 80% objective response rate, as compared to variant 3, 72.3. Variant 2 is having a good response rate, 85.7. And you can easily compare this response with crizotinib 50%, 50% and 73.9%. So this means variant of ALK is again important in sense of a response to the treatment. The variant 1 and variant 3 is having a different response rate as per the segregation of the trial shows. So progression-free survival of EMLA4 ALK variant subtype, median progression-free survival was not reached for variant 1 in the loratinib arm and was 7.4 months in the crizotinib arm. Variant 3, median progression-free survival was 33.3 and 5.5 months respectively. And you can see by this graph that there is an advantage seen with variant 1 with response rate with loratinib. Now I'm talking about the first generation, second generation and third generation drugs. Just see if you are using upfront loratinib, there is an ongoing response which is 36.7 in variant 1. If variant 3, this is 33.3. If you see alcatinib, response rate with the variant 1 is 34.8. If you compare with the loratinib, this is less because of loratinib, there is an ongoing response even after 36.7 months. So if you see the variant 3, the alcatinib is having 17.7, which is almost half as compared to loratinib in variant 3. If you see the brigatinib, the response rate with the variant 1 is 29, again much less with the loratinib, 36.7 and 33 with variant 3, which is only 16. I'm not going in the other drugs. You can see by bar the crizotinib and the crizotinib in Crown trial, ALEX trial, as well as with the ELTA trial, clearly shows that variant play an important role in response of the ALK positive TKI. So resistant pattern after ALK TKI clinically seen in clinical practice, and resistant to second generation TKI is driven by mutations, and resistant to second generation TKI is largely driven by secondary ALK kinase domain mutation, particularly G1202R. Now I am discussing about three things: the crizotinib, ceritinib, as well as alcatinib. If you see crizotinib, there is a mutation like L1196 mutation. Another, I am not going in detail of this. But if you see ceritinib, there is a different mutation, G1200R. And if you see alcatinib again, S1206. and the brown color is showing a maximum number of resistance reported with the first generation and second generation ALK positive TKI. So just see the sequencing of ALK TKI generation lead to more resistance. Suppose you started the first generation crizotinib to the patient, and after 5 to 6 month patient, if there is a progression of disease, no ALK mutation seen at the first progression of disease, but once you switch on the second generation TKI like alketinib, and if there is a progression after 12 to 15 months in between period, there is a mutation reported G1202R. And suppose you switch on the third generation TKI lorlatinib, and if there is a progression, there is another mutation seen, L1196 mutation. This clearly shows that first generation TKIs are having a more mutation as compared to third generation TKI. Now I'm giving a crizotinib. If progression of disease, then alketinib again mutation 1171N, and if lorlatinib in the end, if you are using, there is a mutation L1198 seen in clinical practice. This means as more generation of ALK TKI were sequenced, more monsters ALK resistant mutation appeared in clinical practice, which is reported in the trials. So lorlatinib phase 2 schema clearly shows that the important thing which I want to convey you, that 28 patients treated with one second generation ALK TKI with or without chemotherapy, X38 seen. What is the importance of this? I would like to discuss. The X38 shows number of event 18 and median progression-free survival is 5.5 months, which is much less as compared to other in clinical practice, and the graph clearly shows this. So rationale of upfront use of pan inhibitory agent means once you will use the third generation TKI as a front, I would like to show the F3 cells. If ENU treated, 16 hours later, there is a mutation, and you switch on the 2 ways, 4 weeks incubation, lorlatinib versus crizotinib. I would like to show you the important thing. 100, there is only 2 mutations with the lorlatinib, but crizotinib, even after 300, there is a multiple mutation seen which is resistant to the TKI and cause progression of disease. Lorlatinib suppress the emergence of single ALK resistance mutation. Upfront, lorlatinib could significantly delay or suppress on target resistance. So resistance mechanism to first line lorlatinib, preliminary insight from Crown trial, they mention about that bypass mutations are seen in 9 patients as compared to crizotinib. In crizotinib, there are other methods of resistance also reported. New single ALK mutation seen with 6 patients, ALK compound mutation seen in 2 patients, while 10 patients are having a bypass mutations with crizotinib, which is not seen with the lorlatinib, only bypass mechanism of resistance seen with lorlatinib arm. So this is the total progression-free survival once you are comparing hypothetically with cumulative progression-free sequencing of ALK inhibitor, first generation, second generation, and third generation. If you are using the first generation lorlatinib, this is more than 36.7 months and there is an ongoing response. Suppose you switch on the alketinib as a first line, response rate is seen 25.7 months and progression of disease, and switch on the lorlatinib 5.5 months, then this is only 31.2 months, which is much less as compared to 36.7 months, which is ongoing response. Same thing with the alketinib. If resistance reported and you switch on the brigatinib, the response rate maximum 29.5 months. If you see the brigatinib, if you use as a first line and followed by lorlatinib, then 25.2 months only seen. And if you are using the ceritinib, 16.8 months with the response rate followed by progression of disease, switch on the lorlatinib 6.9 months and total response rate is 23.7. I just want to show you that if you are using upfront lorlatinib as a treatment option, this is 36.7 months as compared to 23.7 to 31.2 months. Even in other choice, you are having a response rate 18.2 months to 32.4 months, which is much less. So you can select the lorlatinib as a third generation TKI as a standard of care to get the maximum progression-free survival, which is ongoing, which is more than 36.7 months. So just see the safety profile. Whenever we are talking about any drug, we always see whether this drug is safe to patients or not. Grade 3 toxicity and grade 4 toxicities are important. More than 20% patient within either arm develop this. But I would like to highlight few important things regarding this drug. The important thing is a weight gain, which is one of the important things with this drug, and peripheral neuropathy, edema, and hypercholesterolemia and hypertriglyceridemia is again a feature of this drug with diarrhea. And important thing is a cognitive effect. Number of times the patient is having a CNS manifestation in due course of a time. But the important thing is how you will control the lipid profile, and there is a contraindication with the atorva drug with this drug. So you need another anti-cholesterol drug which is required for this. HOSA is one of the important drugs you can give if there is a hypercholesterolemia patient is symptomatic. So the important thing which I have noted in the side effect is weight gain, edema, hypercholesterolemia, hypertriglycemia, and cognitive effect, which is very, very important, and weight gain is very important during the management of loratadine. So hyperlipidemia, if you see, there is no intervention required. They resolve during the course of time, but in few patients, they need a modification of the dose, and specifically reduction in the dose from 100 to 75 milligram. And if not tolerating, you can reduce up to 50 milligram in clinical practice. If you see that permanent discontinuation is not seen in the trial except less than 1%. So hyperlipidemia, cardiovascular adverse event occurred in 23% patient of lorlatinib arm as compared to 27% patient with crizotinib group, and in post-ADAP analysis, patient who had hyperlipidemia at baseline or a developed hyperlipidemia during the study 24% and 44% with the crizotinib arm. This showed that although a higher number of patients in the loratadine group had a hyperlipidemia, the incidence of cardiovascular adverse event was not higher with loratadine than crizotinib in clinical practice. So long-term intracranial safety and efficacy analysis on the basis of Crown trial, I just highlighting few things. Intracranial efficacy and safety, you can see that evaluation of long-term intracranial safety and efficacy of loratadine for 3 years follow-up clearly shows advantage even in brain mets or without brain mets. In brain mets, you can see there is a response rate of 73%, while without brain mets, this is 99 versus 50% with the crizotinib arm. So just see the incidence of treatment emergent CNS side effect by the time and grade. No grade 4 CNS side effects are reported. Incidence of CNS side effect progressively reduced with time, and predominantly grade 1 side effect. I am highlighting few things to you. There is a CNS manifestation in the form of cognitive effect, mood effect, psychotic effect, speech effect. But if you see, this is seen in less than 6 months. If you see 6 months to 1 year, psychotic symptoms are disappear. If you see 1 to 2 years, again, there is a cognitive effect, mood effect, psychotic effect, speech effect. And 2 to 3 years, this is again decrease in number, cognitive effect, mood effect, psychotic effect, and speech effect. The bar clearly shows that this is decreasing with time. More than 3 years, cognitive effect you can see, but mood effect, psychotic effect, and speech effect much reduced as compared to the previous in the past. So intracranial safety data, outcome of treatment emergent in CNS, you can see majority of patients, 59% were managed without intervention. CNS adverse effect lead to only 2 patients permanently discontinuing treatment. Long-term analysis confirmed the CNS side effect remained manageable over time. Lorlatinib reduction did not impact cranial efficacy of or penetration of the drug. You can see no interventions required, and even the permanent treatment discontinuation I've shown you in only in 2 patients as comparison to the others. So safety profile, if you compare with loratinib, alketinib, and brigatinib, drug discontinuation due to side effect, only 7% is loratinib arm, 15% is alketinib arm, and just see 13% seen in brigatinib arm. Pneumonitis reported, not reported, but alketinib 1.3 and brigatinib 6 as per the trial suggest. So if you see the guidelines, where is third generation TKI as a first line treatment? You can see the guidelines clearly shows that loratinib is again a category 1 treatment option in patient. And I have shown you the Crown trial where we have a maximum response 36.7 months ongoing response as compared to 31 months with most of the drug, which is much less as compared to loratinib in clinical practice. So just see, this paper is published by me in South Asian Journal of Cancer in 2014, when first patient from the India I reported, those who received, that patient received the crizotinib, and we published this paper for response of treatment of crizotinib when this first generation TKI come into the picture, and I have used this drug as a first line a patient on a compassionate ground from the Pfizer and got the result. Thank you very much for your kind attention, please. Abhishek, thank you very much for your kind attention. Any questions they can ask?
Thank you, sir, for the very crisp and full presentation. It made our concepts very clear and it was very interesting. To the organizers, I think we are over with the today's updates. I think it was a good first day updates with good various good learning points from all the notable faculty which were present here and who took out their valuable time. So I think we learned a lot, and waiting for the day 2 of the updates for tomorrow. So good night to all, and thank you to all the faculty who were